in one of our cerebrovascular Q&A from Swedish Neurosciences Institute and Seattle Science Foundation. My name is Matthias Costa. I'm one of the cerebrovascular fellows at SNI. Today we have the great pleasure of having with us Professor Tateshima. Professor Tateshima is a professor of radiological sciences and neurological surgery at UCLA. He's a clinician scientist and a very productive inventor also, and has been awarded numerous grants, among which we can find an NIH Aero 1 grant for his research into the computational analysis of cerebral aneurysm evolution. He published more than 200 articles and participated in more than 23 US clinical trials, serving as a PI, co-PI, or other roles. He's an avid inventor, as I said, and has numerous US patents. There is a lot more to say about Professor Tateshima. We don't want to take his time, so thank you very much for joining us, and it's a great pleasure to have you.
Oh, pleasure's mine. Thank you very much. So,
I stopped sharing my screen.
Yeah, I can share my screen now. So today I would like to talk about the two new things. I was going to talk about just robotics, but I would like to add one more topic, which is redefining a success of a stroke treatment. We are starting a new clinical trial in the US, hopefully in Q2 this year. So I would like to add that to this topic. First, I have many COIs here, and I don't want to waste my time reading all of them. First, I'd like to talk about the robotics. Swedish there, I know you have a robotic system, and there are so many robotic companies already. Not here, I'm listing not all of them. There are numerous companies in actually Middle East, Israel, Asian countries, and the US as well. Now we use Coindus. It's a part of Siemens system now. And here's the summary of what we can do in the US and outside of the United States. As you know, in the US now, Coindus system is not allowed to use in the neuro-interventional purposes. It's going to be off-label, and also the system is designed to handle coronary intervention or peripheral intervention. So it is capable of controlling guiding catheter and the treatment device, as you know. And the neuro-interventional system, that's slightly different, available in Canada, Oceania, and the European countries. They're treating numerous brain aneurysms. They are not really using that for guiding catheter control. They're using that for the last critical portion of the procedure, microcatheter, manipulation, and the coiling delivery, and the stent delivery. But what I am interested personally is a complete robotic embolization or complete robotics procedure, because eventually, what makes the big difference, well, using a robotic system, interventional robotic system, is remote. In this country, even one of the richest countries on this planet, stroke care disparity is a big issue. And unless we use something very new, like a remote robotics, I don't think we can address this issue. So first, we have to learn how to use a guiding catheter using a robotic system very efficiently. We published this techniques in the JNIS. I know many robotic users are watching this. What we think is very important when we control catheters using a robotic system, particularly for a complete robotic procedure, is a slack control, because we have a very limited working length. It's not robotic limitation; it's a Coindus limitation. So we should not get discouraged by this limited working length. Nevertheless, we have to use this system because this is the only one available. So we would like to reduce the slack. You can see that I'm advancing a Siemens catheter into ICA. To maximize this 20 centimeter working length, we have to remove the slack by using a stiff wire, and you can see that it straightens the catheter and even consuming 60% of the working length here by just removing a slack, we can go into the ICA, enabling a selective catheterization to ICA and ECA. Once we achieve that, and once we learn how to do that, it's just a matter of adding the next 20 centimeter working length for microcatheter control. Even within the current FDA indication for a neuro-interventional field, we can do head and neck embo because it is extracranial, extradural. So by definition, it's not neurointervention, but that's something that we handle every day. So we did our first, or maybe possibly world first, complete robotic intervention for head and neck tumor and nosebleed. And again, the big issue is the 20 centimeter working length. So we have to do the math, and particularly the Corrinder system is closed system, meaning that the catheter and everything has to fit in the system. There is no room for the slack. If we put I do a wrong mass and the guiding catheter is too short, the microcatheter is too long, then the microcatheter has to come out. And then what's going to happen is for head and neck intervention, if the microcatheter comes out like a 10 centimeter, we wouldn't be able to select superior thyroid or ascending-pharyngeal, posterior occipital, lingual artery, unless we put the guiding catheter way down below CCA. So again, this is an issue of the closed system, like Corinda's, but again, it's not a robotic limitation. For example, like a microbot, a disposable system, there is no limitation, there is no closed system. So we would be able to use whatever microcatheter lengths we want, or whatever guiding catheter lengths we want. But at this point, we have to do the math. If we have to use a specific microcatheter that's very long, then we have to use a longer guiding catheter. But knowing the math, we can make current Corrinder system work. And here's the procedural step that we do for complete the robotic head and neck procedure. We put the guiding catheter to the Corrinder system, and we maximize the working length by retracting the robotic system all the way back, and then we navigate the guiding catheter from the arch up to the external carotid artery, and we consume the whole working length. Then we switch to the microcatheter phase. We connect the robotic system to the microcatheter, and we do the rest using a robotic system. Again, this is the complete robotic embolization procedure step. And for injection of the PVA or NVCA, we have to, of course, do it manually. And so far, we did 6 cases. We submitted this to the journal under review now. All of them are on label. And interestingly, we had 2 COVID-19 patients. Also, that shows the benefit of a robotic system. Unfortunately, I don't think COVID-19 is going to be the last pandemic. We're going to experience a pandemic during my lifetime or not. We don't know, but it's very good that we can stay away from contagious patients, still provide the endovascular care to them using a robotic system. And it's not just pick and choose type of cases. We did quite complex cases and still achieved the complete robotic embolization. Underlying vessels are selected using a guiding catheter, and others are selected by a microcatheter. And in each case, we selected 5 vessels per case, a total of 30 vessels selected. So it was quite extensive intervention in terms of the vessel selected. And still, fluoroscopy time was 27 minutes. It was not that long, but the procedure time was actually long, largely due to the unloading and loading of the system to the extent. So the workflow with the Corrinders may not be ideal at this point, although it works. So that's the issue. And here's the thing. The catheter and the wire we use for complete robotic embolization and the manual embolization, they're quite different. We prefer stiffer system, again, for the sake of slack control. That also indicates that in the future, we may have to develop robotic-specific devices rather than using a device that was meant to be used manual intervention. So the slack control, I believe, is the key. I don't know how other robotic users may feel, but that's what we think is very important. And there were some partial manual conversion. One of the reasons was this. Sometimes we particularly for the external carotid artery intervention, we have to control guiding catheter and microcatheter both together. But the issue of not the robotic system, current corriendal system is once system is connected to microcatheter, we lose ability to control guiding catheter, or the guiding system is connected to guiding catheter, then we cannot use a microcatheter. But certain cases, particularly around the takeoff of external, we frequently use the technique to control both together. In this case, we thought that doing so would be much faster. So, for the sake of a patient, and particularly to reduce the radiation dose, we had to convert to manual intervention partially. And also other frequent reasons why we had to convert from robotic to manual was this. Let's say, for neuro-intervention where, let's say, we treat a brain aneurysm, we have a roadmap. Then once we set the roadmap, theoretically, we can stay with that roadmap. We can finish our procedure with a single roadmap because we have anatomy, we have a full understanding. But a tumor embo or dural fistula embo, we frequently refresh the roadmap and we obtain more roadmap, or we do frequent intermittent microcatheter or guiding catheter angiograms to better understand the disease process. For that, the robotic system didn't help us much because every time we would have to unload the microcatheter, remove the wire, and do an injection, and repeat that process multiple times. So in this particular case, patients was having oozing from a necrotic tissue, bleeding out to the skin, and we had to identify those spots. And during that process, we had to convert to manual that enabled a frequent microcatheter injection. And then once this portion is done, we block this bleeding site with NBCA glue. Then the rest of the PVA and the coiling procedure was done robotically. So partial conversion, not like a complete conversion or failure. Partial conversion happens at least in our cities, 33%, 1 out of 3 chance. One was just my error, coil jammed because of the PVA. I should have flushed the catheter a little more carefully. But as long as we rely on manual devices and we rely on actually micro wire to control the microcatheter, then we may not be able to do a frequent intermittent angiograms using a robotic system. So there must be a solution, I believe, and one of the solutions by in doing a complete robotic embo and knowing the limitation of a robotic system, one of the solutions might be a method that Nanoflex, this Zurich-based startup a company, using their magnetic system, it enables us to twist and rotate the wire by just using a magnetic system. It's not just a wire. Theoretically, they can control the catheter. Of course, in order to give a thrust to the catheter or wire or device, it would require a high magnetic power, more than maybe MRI in the bloodstream. So this is just to steer the wire and the catheter, but that may be enough. With this, we wouldn't have to rely on the wire. We would not have to remove the wire and change the shape and put them back in. So frequent intermittent angiogram may be possible, definitely possible. And I think the procedure step will be a little more seamless compared to current system relying on manual interventional devices. So there are many solutions here. So what we experience here is not necessarily a robotic limitation. And here's the brilliant team in this Nanoplex team. And ultimately, of course, if we do it in person, on-site robotic every day, that's fine. But ultimately, the value of a robotic system, no question, is a remote. There is a huge value there because population-based stroke care coverage may be acceptable, but geographic-based stroke care coverage is far from ideal in this country. And people may think that, what about the EMS? Actually, this is me flying. I fly myself, so I know many EMS pilots. I know this field. People think, hey, why not just relying on the helicopter or plane? But we have to be reminded, the EMS, air EMS, they have the highest fatality in all commercial or professional aviation operation. It's not lack of skill set. It's just that we human being, we don't want to divert. If I'm flying myself, or if jet airliner they're flying, if the weather condition is horrible, they just divert. No problem. They follow the law. But if it's a patient in the backseat bleeding and the patient family is screaming, we make a wrong decision, like flying to the bad weather. So as long as humans in charge, in control, we cannot eliminate the crash or fatal crash or horrible crash in air EMS. In order to prevent that, when weather's bad, they cannot fly, which means that we cannot treat all stroke patients. So, some centers where they rely on air EMS and they think they're treating many of them, but we don't know the true denominator. All stroke patients cannot be saved with this system. This is a solution, but not the solution. So I think a telestroke treatment has a future. It's not happening right now, but it has a potential. I believe there are 3 tiers in telestroke treatment. Of course, in Canada, Vito Pereira, he may be starting soon using a coined robotic system, teleproctoring and hybrid thrombectomy, meaning that the guiding catheter, guiding catheter, access to the vessels and the microcatheter manipulation and advancements close to the lesion to be done manually and converting to the robotic system. And then last critical portion, center retrieval deployment, retrieval to be done using a robotic system. But ideally, though, we would like to do everything using a robotic system. That's a complete robotic thrombectomy, and that's our goal. That's why we are trying to do everything robotically in a head and neck space to maximize the learning. And of course, in a teleproctoring, we become just the oral surgeon and then just give the instruction to the on-site physicians what to do. That may be also a way of a telestroke treatment. It may be better than an alternative, which is a long transfer or unable to be transferred out to the thrombectomy capable center. So we run the in vitro study in our angio seat using this model and simulated whether robotic system is equivalent or inferior. If it's inferior, how inferior? To what degree? So we run a study using our realistic in vitro system and measured the procedure time, success rate, and also radiation dose and everything. So we divided in 2 phases because in the complete robotics, this is the phase where we control the guiding system. And then we switch to the microcatheter. It's a microcatheter phase. And here's the actual movie clip of me doing a thrombectomy in this Phantom. I believe this is solid there, but in this actual data acquisition phase, we use the embol trap. So in terms of the technical success, we define technical success as put the microcatheter deploying a stent retriever across the stenosis. Across the occlusion. We put the site of occlusion clot in M1, so we had to go to the M2 and put the microcatheter there and deploy the stent retriever there. So manually 100%, of course, but even the robotic system, it was 100%. And we looked at the first pass recanalization for the sake of time. Then there was no difference in terms of the first pass recanalization rate between manual and robotics. That's very encouraging. But here is the issue of a robotic system, not necessarily robotic system, Corindus robotic system. If we want to do it with the current Corindus robotic system, the procedure time is much longer with the robotic system. For the guiding catheter portion, it's a device incompatibility. We couldn't find a good guiding catheter that works for the stroke, for the sake of a stroke treatment, and that works for the robotic system. So limited availability of the device was a big issue. That can be fixed. And the microcatheter portion, the biggest issue, main reason why the procedure was delayed compared to manual, more than double, was offloading and loading and unloading a microcatheter system. That device exchange, that was a major reason. Both can be fixed actually for the future generation. If Corindus fixes this problem, that's fine. And other robotic company, if they learn from this and fix the problem, that's fine too. So we found nothing. Essentially, it's not a robotic failure. It's just a limitation of a current generation of a robotic system. That's it. And flow time was much longer in the robotic system. This is largely due to the initial phase from arch up to the internal coated artery. There was technical difficulty, and then that delayed the procedure, and accordingly, flow time got longer. Radiation dose, it's not double because the microcatheter manipulation phase using a robotic system, the delay was not related to flow actual catheter time. It was just a manipulation of a robotic system itself. Nevertheless, the radiation dose was much higher in the robotic procedure. And of course, the actual operator radiation dose was much less because I was staying outside. By the way, during this data acquisition, the on-site physician stayed in the room, and I was staying outside throughout the procedure. We communicated via the microphone or just yelling each other, simulating actual robotic thrombectomy. So in this initial complete robotic thrombectomy experiment, we learned that the robotic thrombectomy may be equivalent to manual in terms of the first pass effect or maybe recanalization rate, but it was not that good when we had to chase after a distal emboli because of the frequent unloading and reloading the system that delayed the procedure. Again, longer procedure time than manual. That's a big issue with the current robotic system. But the benefit is significantly less occupational radiation exposure to us. Then, is there a role even using current I would say a little primitive Corindus system? Is there a role for a robotic thrombectomy? There may be. Here's the computational simulation. This is not our publication. This is a publication from, actually excellent publication from a Calgary group. They looked at the best estimated transport strategy with the probability of excellent outcome using Hermes collaboration data. And also they have a geographic data set of entire state of California. They have a data set of transfer time to each primary stroke center and also comprehensive stroke center. And the red area indicates that the patient would achieve the best clinical outcome by having a drip and ship method. Going to the primary stroke center first, give a TPA, transfer it out to the thrombectomy capable center, and have a thrombectomy done. That method. But you can see that if there is a delay in giving IV TPA or transferring out the patient, the green area expands. Green area means that the patient expect the best clinical outcome, much better clinical outcome when directly transferred to the thrombectomy capable center, skipping the IV TPA. So using this data set, we did a simulation. Dr. Beeman is the first author, composed this research idea. So in this simulation, we converted primary stroke center to the robotic centers in relation to the distance from a comprehensive stroke center. Scenario 1, primary stroke center converted to the robotic capable stroke center that are 50 miles away, but 50 miles 50 miles away, but less than 50 miles. Scenario 2, more than 50 miles away, but less than 100 miles away. Scenario 3, more than 100 miles away, and looked at the impact of robotic converting to the robotic capable center. Of course, in a primary stroke center near the comprehensive stroke center, if we convert them to the robotic center, we expect more patients to be treated. And in terms of the number of patients treated, if we convert suburb area, primary stroke center, more than 100 miles away, we are treating less than 250 patients maybe. But actual time saving, it would be very significant. And I cannot imagine even the state of California holding the largest population as a state in this country. Some centers, average transfer time is close to 5 hours. And by just converting them to the robotic capable center, we can save 3 to 4 hours of transfer time. And I don't know your practice, but we know our practice average close to 40% of our patients are fast progressor. So, just in an ambulance for 3 to 4 hours, average 40% patients, they have no hope. So we have to think about very frequent. It's not infrequent that we have this fast progressor. So time saving is critical. So at least in this scenario 3, primary stroke center, more than 100 miles away from a thrombectomy capable center, there may be a chance that even as is, they may benefit from a robotic thrombectomy. So the issue is it's not just the time saving the transfer time. We know that the robotic system is at this point inferior in terms of the procedure time, and frankly, it's equivalent to manual in terms of the first pass effect if we have a right devices. But let's say if we chase after distal emboli, it may be inferior to the manual thrombectomy. So we have to take that aspect into account. But at least in scenario 3, meaning that the primary stroke center more than 100 miles away from the thrombectomy capable center, despite the procedural delay, let's say, I'm very slow in controlling a robotic system and achieving recanalization, almost like a 3-hour delay than my manual thrombectomy. Still, you see that this green area, because given that the transfer time, average transfer time here in Northern California to the nearest comprehensive stroke center is 4 hours, close to 5 hours. Despite the delay, procedural time delay, patient still benefits from the local on-site thrombectomy. Based on this simulation, of course, But what about the recanalization rate? Let's say I'm not that good at using a robotic system, and despite my best effort, my recanalization rate using a robotic system is 10% less than manual. Still, you see this green area, and of course, the procedure success rate goes down to 15% less. Then you start to see red area, which means that with that, the patient may benefit from a drip and ship rather than staying local primary stroke center and undergoing robotic thrombectomy. So we roughly know the threshold. If the delay is within 2 to 3 hours, certain centers, they may benefit of a robotic thrombectomy, and the robotic thrombectomy results should be within 10% compared to the manual in this model. But based on our simulation, we may be already there. So this is very encouraging, as is, of course, I'm not really pushing a tele-robotic thrombectomy to happen right away. We have to go through so many hurdles, regulatory hurdles, and everything, and medical legal issue and everything. But as is, I think we are very close in terms of the procedural success rate. And even every time I present this, people, challenges me. What about the, if the hospital is having a very infrequent stroke patient, how can they maintain, stay current? How those tech nurses, they remember how to use a robotic system, because I'm controlling from far away, but they have to load and unload the devices. That's a good question, but it's not a limitation, because, we just, for example, use the aviation as an example. Fortunately, airplane crash doesn't happen that often, but that doesn't mean that the firefighter at the airport are not ready. They're using simulation. And again, fortunately, pilots, they don't experience catastrophic mechanical failure. That doesn't mean that they are not ready. They use simulation. So maybe once a month or once every other month, those tele-robotic center, they should run a simulation and simulate the loading and offloading, unloading the devices to the robotic system, working with us together to stay current. So I personally believe there is a future for tele-robotics. So that's the robotic thing, and I would like to share a little different topic, which is related to stroke treatment. And I'm personally really excited about this new clinical trial. First, we have to, think about this type of what's the goal of endovascular treatment for large vessel occlusion. Of course, goal is to provide the best clinical outcome to our patients, no question. And we've been evaluating or using a MRS, modified ranking scale, as an indicator, which is good. But here, this is the fact. If you look at, for example, cognitive functions, this is an extreme example, but one study showed that the patient achieved the good clinical outcome defined by MRS 0 to 1 at 3 months. Among them, 70%, more than 70% had a cognitive impairment. That is very surprising. What makes us is a cognitive functions. If this lecture, I'm enjoying intellectual part of my activity, and you are doing the same here. So if the patient is not achieving 100% cognitive function, can we call that as a success? And I can give you another example. I have a family member who had a stroke, and she's on wheelchair as needed. She's on cane, but she's 100% in terms of cognitive function, and I think that was a successful treatment because her cognitive function is completely normal. So there is successful MRS 4, and there is unsuccessful MRS 1. in terms of the cognitive function. That's why I think we need to understand more on the relationship between what we do, thrombectomy, and cognitive function. How can we help not just MRS, but cognitive function wise? And that's why we are conducting this study with the support from a rapid medical cognitive study, cognition and imaging with the tiger retriever. 40 plus sites and 120, maybe up to 450 patients. It's going to be a large study, but this is the first study primarily looking at the effect of endovascular recanalization on the cognitive preservation or improvement. This is an interesting study conducted by Dr. Saver. He's not practicing in Texas. We actually pay attention to the cognitive function. In fact, we use that negatively. The patient with a pre-existing cognitive impairment or dementia, we, looking at the national inpatient sample database, despite severe stroke presentation, it seems like we have a less enthusiastic in treating them. Statistically, with the statistical significance, we do not offer treatment to those patients more infrequently than patients with no cognitive impairment. In terms of the IV-TPA treatment, there is no difference. So we may be going like, hey, the patient's not really doing good. He or she's demented. He's in a nursing home. Let's not be aggressive. That we use that the cognitive function as a part of a go no go decision process. But I personally disagree. Whatever patient pre-existing condition, they I think benefit from endovascular thrombectomy. But that being said, we are not really paying much attention to the point that I think a very important point that what we do really helps the cognitive function or not. I think it helps, but there is no study. And if we review the manuscript, there is no consensus, but based on the reviews, post-stroke cognitive impairment is defined as 3 to 6 months following the stroke. It's not cognitive impairment after a year or a couple of years, because that may not be necessarily related to index stroke. And some cognitive impairments are lesion specific, cortical lesion specific. Some are not lesion specific, more like anatomical circuity, depending on the fibers connecting to part of the cortical tissues. Maybe executive functions or vascular cognitive impairment, they are more related to white matter rather than local tissue, cortical tissue. And I showed the extreme example showing a 70% or greater chance that even achieving MRS 0 to 1, they have a cognitive impairment to some degree. But average post-stroke cognitive impairment seems to be ranging 20 to 40% at 3 months. And some paper shows that the 1 out of 4 chance that they may recover after reperfusion or treatment. There is actually a study showing the benefit of IV-TPA recanalization in terms of the preservation of cognitive impairment. There must be a correlation between recanalization and the cognitive function preservation. And most of the literature shows that the recovery takes place within first 3 months. So learning from that, we are composing our clinical trial design. And in terms of the cognitive test, again, I talk like I know something, but in full disclosure, I didn't know anything. We were interested in cognitive study, and as we speak, and we are learning from a neuropsych specialist, and people use a mini mental state examination and a MoCA and other cognitive battery. In this cognitive study, we decided to use MoCA. I think a mini mental state examination based on the past publication is not sensitive enough. And of course, ideally, if we use neuropsych battery, the sensitivity increases, but the issue is, it takes much longer time. And if we set primary endpoint relying on neuropsych battery, then we may expect a lot of primary endpoint failures because just it's too extensive. So here's the actual, here's the boards and committee of this cognitive study. PI is myself and co-PIs, Justin Singer and Fawaz Al-Mufti. And trial steering committee includes neuropsych specialist and neurocritical care specialist, because we need that. We are learning, we are redefining a success of endovascular thrombectomy, and for that we need the help from a neuropsychiatrist. And special thanks to Rapid Medical employees, Dr. Haddad and Bates. So here's the primary endpoint. We think, we believe endovascular successful reperfusion helps to preserve the cognitive function, and we define success as a MoCA of a 1.5 standard deviation from 4 days post-endovascular thrombectomy or discharge if that happens earlier, comparing against 180 days. Or if the patient achieves MoCA greater than equal to or greater than 26, that's by definition normal cognitive function. Even if within a 1.5 standard deviation change, we define as a success. And we believe that the TK2B or better recognition is associated with better chance to achieve a higher delta. It means cognitive impairment improves. So, I don't want to read everything and to bore you guys, but what's unique about this study is also this area. We are wondering whether TK, although we are using TK, we are wondering whether TK is really sensitive to the cognitive impairment, because when we looked at the cognitive impairment in posterior and anterior circulation, surprisingly, the instance of a post-stroke cognitive impairment rate is equal. It's really not more frequent. It equally happens in the posterior circulation, presumably due to the involvement of thalamus. How can we tell whether thalamus or thalami are well perfused reliably using angiogram? It may be better to rely on perfusion, cross-sectional perfusion imaging. So we are looking at the perfusion imagings. Not all sites will be performing this because it's outside of standard of care, but some sites where they do post-thrombectomy perfusion, we collect that data and compare against the post-stroke cognitive impairment. And we do MoCA at discharge, and we do 30 days and 180 days, but we also follow them up to 1 year to maximize our learning. And just for the safety, we use a CRAT cognitive battery. CRAT stands for consensus of to establish a registry for Alzheimer's disease. So this is meant to be used for multiple times to evaluate the progression of Alzheimer's disease. So this is ideal, but the little issue is it takes longer. It takes maybe 20, 30 minutes at least, whereas the MoCA test, as you know, it takes only 10 minutes or so. But again, we maximize our learning. MoCA may not be sensitive enough. Then our backup is CRAT, the neuropsych cognitive battery. And I don't want to bore you guys by reading all of these, but in this study, we're going to maximize our learning. For example, we think MRS is not that sensitive, and based on the MRS, we define our success, or we excuse ourselves. For example, post-thrombectomy subarachnoid hemorrhage is quite common in M2 based on our data, 25 to 30% chance that we induce subarachnoid. It does not affect the NI stroke scale. It does not change the MRS based on the many analysis, including ours. But what about the cognitive function? We don't know that. So we would like to look at the serious adverse events and the cognitive functions. We would like to compare social behavioral factors and cognitive function. We will be looking at so many variables to maximize our learning. And a couple of things. This is not IDE. This is a post-marketing study. So we have to follow our indication for tiger retriever. And staying within indication, we have to modify a little bit. Most significant one is the age. Based on this publication, again, Dr. Saber's publications, older than 80-year-old population of in this thrombectomy cohort, 1 out of 4 patients had a pre-existing dementia, which means that it's by definition for the same reason that we do not include the MRS pre-existing MRS 3 or 4 or 5 for stroke trial. We have to exclude the patient with pre-existing dementia, otherwise we lose the signal benefits. And that's why we changed the inclusion criteria. For FD indication, it's 18 to 85, but we changed to 75. And also, we exclude the patient with probable amyloid angiopathy because of high association with Alzheimer's disease and cognitive impairment. If there is a pre-stroke diagnosis of dementia, we do not enroll those patients to this trial. And also, patient has a pre-existing major depression that affects, it's not dementia, but that affects the cognitive function test. So we exclude them from this study. So we are, again, this is a very first study. As we go, we learn a lot, and there is a chance that we may not achieve the statistical significance, but at least we try our best to increase the signal of endovascular benefiting the in preservation of a cognitive function. This is my last slide. This is the timetable for this study. We are looking at also 5Q, EQ5D, other than MRS, CRAT, MOCA. So whole purpose is to maximize the learning from this study and set the new goal and trying to define a success from a different perspective. Again, what makes us is a cognitive function. It's a shame that we have not been paying attention to that aspect for our stroke thrombectomy cohort. And I always tell this to the folks after my presentation. I gave a talk about this cognitive function, cognitive trial in a couple meetings. I'm so positive that regardless of the outcome, we're going to learn a lot. And frankly, I think that after completion of this study, we end up having more questions than answers. We get answer, but I'm sure we get more questions, and that's going to lead us to the subsequent refined trial. And my boss, one of my mentors, he used to say that, Fernando Vinela, he used to say that a research idea or research end up with having more questions than answers is a very good one. By that definition, this is going to be a very good one, I believe. But for now, not so many tough questions to me, please, after Q&A session. Thank you very much.
Thank you so much, Professor, for your talk. It was amazing, very innovative, and really interesting. So we have a couple of questions. Dr. Montidis online, first of all, is the director of cerebrovascular here at Swedish. And Dr. McDougall needed he left because we have a stroke now, so
Okay.
he's doing a thrombectomy. He apologizes for leaving early. So we have Dr. Moti. Do you want to ask something before I run my questions?
Sure, Satoshi. That was a great talk, and thank you for joining us today. I had sort of a comment or a question. You'd mentioned about the issue of smaller centers being trained to avoid the transfer time, and that's the question that we kind of really have with the Corindus. We found there's a lot of training involved for our own team, and the number of cases that we needed to get them up to speed, was quite a few. And just the question is, at 2 a.m, training a remote site who does maybe 10 strokes a year to be efficient and be able to do, these cases robotically. My question is, do we think, or what techniques do you think, simulations or trials, do you think you could do to get them up to speed with such low volume? And then the second question is, would we be better off training our radiology or cardiology colleagues to do the thrombectomy instead at that local site?
Great question. Thank you. Yeah. So I fully agree. Training, even sometimes I forget about how to use cassette. First, in our in vitro study, we intentionally used the physician who didn't have any robotic experience, staying right next to the phantom. And in order for us to feel comfortable moving to the data acquisition phase, from the test run to data acquisition phase, it took us maybe 15 thrombectomies. It took him to feel comfortable after 15 thrombectomy, loading, unloading. So that's, I think, the number. It takes more than 10 cases. And that's also tells us that, local sites, I think they should do at least ideally once a month, not just the one unloading and the loading, maybe 5 to 10 to stay current. That's a requirement. And also training a cardiologist and a radiologist. I think that's a solution. Like I said, there are 3 tiers in a tele-stroke treatment. One is a complete robotics, one is a partial robotics relying on local physicians, or we relying completely on a local physician, right? Just training them. I think that's a great model using a system like a Veil that's available. But another issue is whether they stay in that hospital. In like a prestigious sites like a Swedish there, you establish your career and the people stay there, but the local hospital, the physician may not stay there, right? And the securing a human resource is a big issue. I think that's the issue of a stroke care disparity. And you're there, I'm here, right? So as long as the robotic system's there, at least we can provide expertise. So I don't know one solution, but and the training a cardiologist or radiologist there partially trained may be a solution, but how can we guarantee their employment? How can we keep them there? I think is a big issue, and maybe telerobotic maybe is more reliable for that regard.
I think that's a great suggestion. Having the hybrid situation might be where this ends up. I think as time goes by, we're going to see different setups in different places across the country, depending on the human resources that you mentioned, and it's probably going to figure itself out.
Yeah.
But it'll be interesting to see. Thank you.
Okay. Dr. Patel, Dr. Patel is one of our attendings also. Do you want to ask something before I proceed?
Yeah, great talk, Professor Tateshima. My question really
can't hear you very well, Akshal.
Yeah, microphone.
Can you hear me now?
It's really muffled.
Muffled. Yeah.
Is it better now?
Yes. Yeah.
Okay. Sorry. Thanks for your explanation, Professor. In answer to Steve's question, I'm not sure if this is more of a question versus a comment, but my concern is, robotics companies need to start thinking about being catheter-based companies too, because right now we're adapting a lot of the catheters and devices for the robot. And I wonder if in the future we need to start doing the reverse and design catheter, and then the catheter companies have to start now designing catheters for the robot, or devices need to come out robot specific. Do you think that's a better way to go, especially what helps people so they don't have to worry about what works with what, trying to figure it out? Is there a company out there that's now designing reverse engineering catheters for the robots?
It's a great question. I answer is, I don't know they are designing stroke specific system. Actually, there are a couple companies designing for stroke system, robotic company designing for stroke catheter and everything. So answer is yes, but to be honest, nobody knows what's the right direction. Many companies, I have to respect the NDA, but many companies, they are trying to be compatible with all existing devices and refining them. That's one way, but the really bold, gutsy company, they are, redefining stroke treatment. One of them is actually, I included one slide, the Nanoflex. It's very impressive. With that technology, we may not have to use the wire, simpler system. And a simpler system means less manipulation of a robotic system, means makes the procedure much faster. Yeah, there are companies making a bold movement. And another thing is, I think telerobotics and on-site stroke treatment, they are different, right? Stroke telerobotics, it may not be as good as actual manual thrombectomy, because we can virtually do anything, but the robotics is very limited. But it has to be better than alternative. If it's just better than alternative, it doesn't have to be super complex combined techniques, things like that. It may be simple aspiration, maybe enough, right? So to answer your question, I think I personally believe that the robotics specific catheter, paying more attention to ease of use, may be a way to go, and it should be a different evolution than the manual thrombectomy.
Thank you.
Okay, so Professor, a few questions regarding your talk. First of all, how do you think the medical legal issues and the legislation is going to change the way we see telerobotics? Because who's going to be held accountable and who's going to be responsible for different medical legal issues if we're performing a procedure from a different state or remote location? And I don't know.
Yeah, so the answer is nobody knows yet, but the fact is we are doing a telemedicine already, right? Particularly for the stroke, our stroke neurology colleague, they're doing a telemedicine to make a diagnosis and give a TPA, and they're privileged at that hospital. So I think the same principle applies. If I do thrombectomy, I should be privileged at that hospital, and I should be liable and accountable for the consequence. Given that, I don't see a reason why we treat aneurysms remotely, because that's the patient cohort that we can wait. Those patients can be transferred out, and the outcome may be better for manual in-person treatment rather than robotics. But the issue is LVO, like I showed. Remote centers, those patients, they'll be in ambulance for 4 hours, 5 hours, having ICL, MCA blocked. And what's the vessel perforation rate? What's the severe adverse event rate associated with our thrombectomy? It's very low, right? So we compare the risk benefit and we achieve some consensus. Certain procedures, such as a large vessel occlusion thrombectomy, I think the patients benefit. So in terms of medical legal issue, we have to think about the risk and the benefits. And I don't expect the remote robotics. We have a like almighty approval. It is, I think, a procedure and a disease condition specific.
Okay. Another question is regarding the haptic feedback. Many there are some groups working on like doing some bench studies on how to improve the haptic, like the sensation, the haptic feedback on the robotic systems. How do you think is it doing any progress? What do you think about it?
Yeah, I know a couple companies working on it, and even the Coindas had a pressure gauge. And it's better to have more information, no question, right? But again, we can learn from our surgical colleagues who's been using Da Vinci for decades. And initially they were so against like what about the haptic feedback? This is useless. And now, like a urology, or those colleagues, they love the robotic system. Their tone has changed completely. They're like, oh, without haptic feedback, we use shadows, we use a deflection of the tissue, we rely on visual information more than ever. We are very creative. We don't have a haptic feedback, then we look for something else to make it work. And I don't think most popular robotic system, surgical robotic system, Da Vinci, they do a great job without haptic feedback. So the same principle may apply to us. We have a publication. It's not a publication. We have a case report. Our very first spinal angiogram. And we rely on deflection, and as needed, we use the wire deflection to substitute the haptic feedback of a catheter selection, catheter engaged in a segmental artery. So it would be better to have haptic feedback, but I think we can do without it.
Okay, sounds good. And a few questions about the trial that you're conducting, the cognitive trial.
Mm-hmm.
So first of all, you won't get a baseline of those patients, obviously, because it's unpredictable. So right. You're going to compare 72 hours post-thrombectomy with a more remote
180 days.
Okay. And how can you differentiate between, the prevalence of like post-stroke depression is around 25% and can also produce cognitive impairment.
Right.
Do you have any tool to differentiate between those kind of depression and
Good question. First of all, we do all patients. We do EQ5D test, and it's going to be 5L. So as you know, that involves the mobility, self-care, activity, pain level, and the mood, including depression, right? So we're going to collect that data. So if the patient is suffering from a post-stroke depression or not, we collect that data. And also we exclude the patient with a pre-existing depression, right, to maximize the signal. And also, with that data, we can differentiate whether a certain area of cognitive domain is affected by the depression or not. It's from the index stroke. For example, there's a data showing that having a depression, particular domain like attention, is affected. If we see many patients with a known post-stroke depression achieving a low score in attention, then we know the reason. So again, I'm not a specialist. We are not a specialist, unfortunately. So this study is going to help us learning in association.
Okay. Are you going to include anterior and posterior circulation, or only anterior circulation in the cognitive?
Great question. Both of them. Actually, incidence of a post-stroke cognitive impairment is nearly equal in anterior and posterior circulations.
Nice to know. Okay, and why did you specifically choose Trigger? Because some industry sponsorship of the trial, or you
Yes.
believe some difference? Okay.
Yeah.
Okay, nice. And will you differentiate between patients that got thrombolytics before and after, and do you think there will be an impact on?
That's a great question. Maybe and that's going to be subgroup analysis, no question. And you know, the study like a choice trial, post thrombectomy IVTP usage showed the benefit in terms of the MRS. May show benefit more in terms of cognitive functions, and
Right.
also. Based on our UCLA data, post-thrombectomy distal emboli or new emboli rate is almost like a 40% based on the DWI.
Yeah.
And the high definition, high resolution DWI, it's not UCLA data, European data shows 80% distal emboli. So I'm sure there is a positive effect on the usage of IVTPA.
Okay, a few questions about the hardware that you showed, the NanoFlex. What is the state of that product in the market? Because there was a previous magnetic system that I remember, the Niobe, right?
Yeah. So
magnetic. Yeah.
It's again, you know, I have to ask them, but they're very close to first in man, I believe. I mean, part of their system, not the entire system, but I like their approach. I really like their approach, and you know, there are many other companies doing a very gutsy thing, trying to move everything using a magnet, but that would require humongous, you know, very strong magnet that I cannot even wear a watch. We have to remove the old wallet, and like maybe worse than MRI. That's not realistic, and their magnetic field strength is not that significant. That's not strong enough to deflect. Yet I think their system may be feasible to move the microcatheter, and if that happens, then we don't have to rely on the wire, and then the device selection could be simplified, and also that enables us to do intermediate angiogram easily using a pump from a microcatheter. So yeah, I think I see a huge potential in NanoFlex, the company's system.
Yeah, and you can also decrease the time because you don't have to exchange or reshape the wire or whatever.
Yeah, exactly. Yeah.
Okay, Professor, those are my questions. There is a question from the audience, I think, regarding the check. So probably one of your colleagues from psychiatry or whatever can answer better, but a person from one of the physicians from Afghanistan asks, what is your recommendation for medical management of post-stroke cognitive impairment?
To be honest, we don't know. We do not know at this point that this study will tell us. But one thing that I can tell based on our experience and publication is I think that we have a consensus. There is no reason to skip TPA, even for the sake of time. TPA administration doesn't delay, and based on our data, it's not a choice trial. The patient who had an IVTPA before thrombectomy showed the slightly better clinical outcome, and we didn't understand why. We did not understand why, and then we started to realize that what we do causes a lot of distal emboli, and it's not from the initial impact. In fact, we found multiple distal emboli in TK2B recanalization group, not the TK 0 or 1 or 3. So what we do sometimes gives some harm to the patient, right? So we have to be aware of that aspect. So it's not medical management, but we do our best not to cause distal emboli. That may be silent. We don't know, that's what we are causing. That's one thing. And also another aspect that actually in the cognitive trial, we are paying attention to post perfusion, post thrombectomy perfusion. And I'm sure you have the same experience. If you pay attention to the post thrombectomy perfusion, some patients, despite the high quality 2C or 3 recanalization, we see poor perfusion, right? That may be silent due to silent emboli. And using a post-thrombectomy perfusion, the blood pressure parameter may be set accordingly. We should not be just relying on angiogram. Perfusion study may help us better in terms of the post-stroke management. So that could be an answer. We just post-stroke management should not be. We should not rely on just angiograms, perfusion imaging.
Great. Okay, Professor, it was an amazing talk. Thank you so much for joining us.
Oh, thank you.
Honor for us, and I hope we can invite you again at some point.
Oh, please, I love Seattle. Actually, that's the first state, first place when I was 16, I came to US to actually Seattle. That was the first place, and I'm sorry, this is a live stream, but do you still have a I Love Sushi there? Sushi place?
I'm not sure.
Akshal's probably the one to answer that. He's the senior expert in the department.
Yeah, so a friend of mine, actually my father's a close friend, they run in multiple businesses there in Seattle. So yes, I'd like to be there. If you invite me, I pay out of my pocket. So anytime, okay? Anytime.
Okay, sure.
Sounds good.
All right.
Thanks again, Satoshi. That was awesome.
Thank you.
Thank
Okay.
you.